propagation of the infection from the vicinity of the organ, but about 25% can also be caused by hematogenous spread, for example, from the lung or the skin, and 10% is iatrogenic. Iatrogenic means that it comes from facial trauma or from the surgery, open skull surgery, or other causes, Okay, so this is the important lectures here. I think this is the most important one. We have 4 phases of brain abscess. The first one is the early cerebritis. It means that the lesion is not yet clear, and then the beginning of the abscess or infection is marked by early cerebritis. So there is a offered inflammation that takes place, plus the edema, but we cannot yet pinpoint where is the abscess, so we cannot see really the location or the focal area involved in the abscess. It usually happens at the beginning of the abscess formation, that is day 1 to day 3, and then moving on, we can already see some expansion of the abscess. So the previous non-offered area of abscess now becomes more firm, and then we can see the formation of the pus plus the necrotic area, but it's not yet localized. You usually happen after week 2 can already see the enhanced, where the capsule rings become more clear and clear with a firm border, and then the enhancement is very obvious when you do perform CT scan with the contrast. So for example, this image type, this is the early cerebritis. This one is the expansion, and then this one is also the expansion. You see this from the CT scan, and this one from the MRI. We can see the focal area, necrotic area. This one, but not yet forming a ring. On the MRI, we can see edema marked by the white or hyperintensity area on the right frontal lobe. And then on the B here, on the this picture, you can see the ring has already been very well formed. This is a CT scan with the contrast, So this is the rim enhanced brain CT scan. This is probably will be late capsule state, So this is the clinical manifestation of someone with abscess. Sounds like pretty much like a meningitis. We have fever, we have headache, and also reduced mental status as the early signs. And then moving on, if the patient is not well resolved, then we can start to see focal neurologic deficit with late seizure, and then we can also see granuloma according to the area affected. So frontal, we can see hemiparesis or motor aphasia, because this is a motor area. In the temporal, we can see sensory aphasia. With cerebellum, we can also expect any ataxia or nystagmus to develop in the patient. And intracellular, this is near the sella turcica. This is the area where the pituitary sits. So if there is any compression to the pituitary gland, then it can also cause a variety of hormonal aberrancy expected to be seen in the patient. So these are the differential diagnoses. We can see, we can expect, or at least suspect them to have acute bacterial meningitis, brain tumor, neurocystic sarcoidosis, or TB. We will explain this later after this. The treatment depends on several factors. The first one is the onset when the patient comes to you. If it's early cerebritis, if it's not really obvious, the abscess, if the pus formation is not well defined, and then if the size is less than 2.5 centimeter, and if the number is multiple, then you opt not to do any surgery. We treat it instead with antibiotics for about 1 to 2 months, so for about 4 to 8 weeks, and see You can redo the CT scan or redo the MRI to see if there is any resolution of the symptom or of the lesion on the brain. Yeah. But if it's already capsular formation, either early or late in capsule formation, and if the size is gigantic, more than 2.5 centimeters, and if the number it's only single lesion, and especially if it's superficially located, maybe it's near the skin or the parenchyma or the pericranium, and then you can opt to do surgery. Yeah, you can do surgery. You can aspirate. You can drainage the pus, and then plus the antibiotic for another 4 to 8 weeks. These are the choices of antibiotics. You can see here. We can use the broad spectrum antibiotic like ceftriaxone and cefepime. This is the 3rd generation cephalosporin across the blood-brain barrier, so it's effective in treating any pathogen or bacteria that involves the brain parenchyma. You can also use the beta-lactamase analog like meropenem. Cefadexime is also another 3rd generation cephalosporin, and this is the most important one. You can use metronidazole. Yeah, metronidazole is effective against anaerobic bacteria. Yeah, so it's effective for those bacteria that favors growing in area with lack of oxygen. So you can use the combination of 3rd generation cephalosporin with metronidazole for 500 milligrams 4 times daily to treat anaerobic bacteria if there is any co-infection. Yeah. Or if the patient is intolerant to metronidazole, or if there is a MRSA, multiple resistant bacteria, this is the multi-drug resistant Staphylococcus aureus, you can also consider treating them with vancomycin instead. Okay, so these are the pathways. You can learn it by yourself. The point is, if again the abscess is more than 2.5 centimeter, solitary, superficially located, you can consider doing the excision of drainage instead. But if it's multiple with sizes less than 2.5 centimeter, and it's deeply located, or in areas that surgery may not be possible, then you choose to treat with the empirical antibiotic treatment here. Yeah, cephalosporin plus the metronidazole for 4 to 8 weeks. Okay, then move on. Okay, this is the TB. Yeah, spondylitis TB. Yeah, TB that's affects on the vertebra. Yeah, so if TB usually infecting the lung, but when it comes to the vertebra, it can also spread there. Yeah, it is relatively rare, only 2% of all TB cases, but about 15% of non-lung TB can be found on the vertebra in the form of spondylitis TB. Yeah, TB spondylitis, usually associated with lung TB. Yeah, 67% or 2/3 of them are associated with lung TB, either during the active state, subclinical, or latent TB. Yeah, and it's especially happening on children or young adults because of their well-vascularized area of the spine. Yeah, so every type of infection of TB usually begins with the first loculation on the patient's lung, and then it forms a focal area of infection. We call it as gonfocal. But later on, when the focal is breaking down, so every kind of bacteria will be spreading around the blood, and the bacteria will be carried out through the bloodstream, crossing the blood-brain barrier. Either it goes into the brain, causing meningitis, goes to the brain parenchyma, causes meningitis, meningoencephalitis, or going to the spine, that causing the spondylitis TB. Yeah, we call it Pott's disease. This is the term of spondylitis TB TB spondylitis in the U.S. Yeah, and the type of spread can varies, but usually we can divide it into 4 types. The first one is paradiscal at the location of the center of the vertebra, the bone. We call it as center type. vertebral plexus. So we have a bloodstream, we have a venous plexus around the spine, and like through the Batson plexus, and then it can inoculate inside the spine and then causing the Pott's disease or TB spondylitis. Yeah. Okay, so back to the Batson plexus. Here you can see this. The interior part or non-osseous part, this one, yeah, this area. But if the Batson plexus affected is the middle, then it will cause any peridiscal, either peridiscal or central TB spondylitis TB, yeah. Or if it's in the posterior around the spinous process, you can see here, then the infection will develop in the posterior part, therefore causing the posterior type of infection. Okay, so this is another description of the location. Yeah, peridiscal means around the disc. Yeah, it can affect also the bone and the disc predominantly. If in the central, it is predominantly located on the bone, yeah, vertebra. And then if it involves another layers of bone, it is not in the center. We call it as either epiphyseal if it affects this one is the spinous process, or the pedicle, or the superior articular pillar of the spine. It can also cause problem in the bone, yeah. Or in the interior, in the vicinity of anterior longitudinal ligament or non-osseous part of the spine. Okay, so these are the symptoms. So we have systemic symptoms like fever or malaise, weight loss, night sweats, and then we have also a problem with if it affects the meningitis of the patient or meningoencephalitis, we can also have neurological difficulty, yeah. Plus, if it affects the spine, yeah, we can expect also problems from the spine, like back pain, kyphosis, fracture of the bone, and then once it disintegrates and cause compression of the spinal cord, we can also expect neurological deficits like paraplegia, spasticity, walking problem, clumsiness, spasm, everything can be related to the infection. And especially dominant on children and younger adults because of their well-developed vascularization in non-stenotic area. Okay, so the working diagnosis can be supported by supporting examinations. We can do the lab works where we expect increase of the ESR or erythrocyte sedimentation rate, increase of the inflammatory markers like CRP, and we can also do the TB sputum test or gene expert, yeah, to detect Mycobacterium tuberculosis gene during the PCR test. And we can also do with respect to the Pott's disease, we can also do the MRI as being the gold standard. We can evaluate all of the structures on the spine, the bones, the discs, the nerves, everything we can see clearly on the MRI. But if you don't have MRI, at least we can do the X-ray, yeah, on this chest lumbar, thoracolumbar X-ray. We can see here, this is the lateral view, this is the AP view. We can see deformity here around the L1, yeah, this is the ribs, so this is thoracic spine level, the last one being level 12. Visibility of the L2 and we can do lateral view. We can see the collapse of the L1 blood here. This is the sacrum. Yeah, this is the sacrum. This is L5, 4, 3, 2, 1. Yeah, this is the one, the first lumbar area. And we can see already the encroachment, but and then allows it to level, indicating that this is a vertebral fracture. The treatment consists of one is rehabilitation for increasing the patient's chance to be mobilized again, to be active again. Okay, I think that is the end of the slide. I will stop share screen. Okay, any more questions? Any questions, guys, to the one who already explained to you? If there is no questions, I'll give you some clues to what questions will come out tomorrow on the exam. So please learn about all the physical exams, because the questions are so easy and you can easily get the scores on that. I've already made like 8 questions, coming out from all of the physical exams. Those are very easy piece of questions, so make sure that you can get all the questions right. Please learn about pathological reflex as well. Please learn about the difference between Babinski and their family, plus the Rossolimo and Manufacturer. And then you can please learn about the meningeal signs as well. The difference between Grudzinski 2, 3, 4. Please learn about it. And then for infection, please learn about the images or the pictures, because some of the questions will have pictures on it, and then you have to define, you have to diagnose the patient, and then the question will be about the treatment, and the treatment will differ slightly between one and another options, so make sure you choose the right one. Please pay attention to the what is asked by the question, because some of the questions will ask you about the initial treatment, but some of them will ask about definitive treatment, some of them will ask about supportive treatment. So please pay attention to what the question is asking. If it's initial treatment, then choose the most reasonable one. Initial being maybe stabilizing the EBC will be the right answer to go, but for the definitive treatment, maybe if it's meningitis, then choose antibiotics, or if it's a supportive treatment, then you can choose a treatment that can comfort the patient, or reduce the symptom of the patient instead of treating the definitive cause of the illness, and then please pay attention to the pictures, pictures related to the CT scan or MRI, and please learn about the lumbar puncture, how to differentiate bacteria, virus, other pathogens. So according to lumbar puncture, microscopically speaking, so pay attention to the color of the LP, about the number of the cells, white blood cells, and if there is any glucose levels, glucose high, low, or medium, and the ratio of the glucose on the CSF and on the blood, please pay attention to that area as well, and then for the vascular, this is for the IC only, because I teach about the vascular. Please learn about the circulation of the brain, where is the anterior circulation, where is the posterior, and please learn about the symptoms, of the posterior circulation. If someone comes to you with a stroke on the posterior circulation, what are the symptoms that can differentiate between the posterior and anterior circulation? Those are two maybe slightly different but important. I've already explained all in the lectures, so please refer back to the lectures again and look at the difference between anterior and posterior. Please learn about definitive treatment of the stroke. If it's ischemic stroke within golden period, what can you do about the patient? I'm not talking about the dose, but I'm talking about the choice of the treatment. the most appropriate treatment you can give to the patient. We're talking about definitive treatment. Yeah. And then please learn about PRES, posterior reversible encephalopathy syndrome, hypertensive encephalopathy as well. Wait, let me check again for the question. I'm not sharing screen, right? Okay, because I'm opening the question right now. Yep. Okay, please learn about the criteria for thrombolysis. Yeah. What are the indications and contraindications for thrombolysis? Yeah, that's only I can say so far. Yeah, and then please learn about the brain hemorrhage. Yeah, etiologies of the brain hemorrhages, what kind of etiology that you can find, and then please learn about topical diagnosis. Yeah, so if the patient come, for example, a patient, maybe a 50-year-old male was brought to the ER with a complaint of sudden facial droopiness, and then right-sided arm weakness or extremity weakness on the right side. The pupil is pinpoint. Minimal responding to light stimulation. What is the most likely area affected on his brain? Yeah, so you can discern, and please pay attention to the right and left. Yeah, which one is the most appropriate according to the clinical examination. Yeah, so topical diagnosis is important because some of the questions will arise from there. And please learn about the risk factor of stroke, either traditional or non-conventional risk factors of stroke. It can also happen to come out on the exam. And about the Parkinson's, yeah, this is for the IC again. Please learn about the mechanism of action of each of the medications. Yeah, so we have several pathways. It's already been in the slide with the pictures. Yeah, learn about it. Yeah, so which medication inhibits which enzymes, please learn about it. I think that will be all. I cannot disclose everything, but I think I've already mentioned all the majorities of the questions. Any questions? Ya, Jenny, please.
Kalau misalnya yang buat pertemuan pertama yang nyeri sama pengenalan Arab, itu apa dok yang harus dipelajari?
Nyeri ya, oh iya, nyeri itu di awal-awal ya. Nyeri pelajari semua sih, nyeri itu sedikit ya. Jadi saya disuruh bikin 5 soal tentang nyeri. Jadi pelajari semua sih. Kalau nyeri itu patofisiologinya, kemudian obat-obatannya, terus jalur-jalur nyeri ya, yang itu, yang konduksi transmisi, modulasi, persepsi itu tolong dipelajari juga. Kalau untuk yang pengenalan kuliah pengantar, itu belajar anatomi ya, anatomi, kemudian fungsi-fungsi korteks cerebri, terus area-area Brodmann ya, itu tolong dipelajari. Terus area-area otak lain ya, jadi batang otak fungsinya apa, talamus fungsinya apa, terus ya hipotalamus fungsinya apa, itu tolong dipelajari. Itu ya.
Oke, thank you dok.
Ya, ada lagi pertanyaan? 1 menit, saya kasih waktu 1 menit. Ini nggak direkod kan ya?
Enggak dok.
Linear. I don't know Jessica. It can either come out or not. Linear ya, coba cek dulu ya. Ada nggak ya? Ya, kalaupun ada, soalnya nggak banyak sih. Karena linear tuh saya nggak bahas banyak ya. Yang saya bahas cuma singkat-singkat, ya soalnya juga nggak banyak-banyak. Kecuali mungkin Parkinson ya. Parkinson agak banyak sih soalnya. Ya pelajari yang high yield ya, yang banyak materinya, yang soalnya banyak, yang kemungkinan kalian akan kalau jawab benar itu bakal sweep banyak skor, yaitu yang difokuskan ke sana ya. Oke, ada lagi pertanyaan? I don't know. Bales Malsi kan lumayan kemarin banyak soalnya ya. Bales Malsi ada beberapa soal ya. Jadi ya tetap dipelajari ya. Kalau Bales Malsi tolong pelajari yang gambar itu ya, jalur-jalur yang dia keluar dari MAI ya. Tolong dipelajari ya. Oke. Ada lagi pertanyaan? Oke, kalau nggak ada pertanyaan lagi saya akhiri ya pertemuan hari ini ya. Sekali lagi minta maaf ya untuk IC, ini miskom banget. Dr. Rosalin juga tidak memberikan solusi yang konkret. Saya diminta untuk ganti soal tapi agak kesulitan ya karena saya sudah submit dari minggu lalu soalnya. Jadi daripada saya ganti soal, mending saya kasih kuliahnya aja. Dan tolong dipelajari banget untuk infeksi ya karena banyak keluar ya. Oke, kalau nggak ada lagi kita akhiri ya. Terima kasih semuanya sudah berkenan hadir di kuliah hari ini ya. Selamat malam, semoga sukses ujiannya besok ya.